first of all, good morning, everybody, and thank you very much for having invited me to speak in this Congress. Thank you very much to the colleague for the opportunity he gave me to speak a little bit earlier than it was scheduled. And I would like to talk to something a little bit different. First of all, apologies for my bad English. I would like to talk today not about clinic, but about protocols. There are many possible protocols we may follow to manage breast cancer, and I would like to check 3 of them and take a look at which is maybe the best one. So as my colleagues have said before, breast surgery and the surgery of the lymph nodes has had a great development during the last century. Of course, we have begun from the mastectomy, and nowadays we are, for many patients, arrived to the conservative breast surgery. The same is, this is an image, of course, and this is an image of a mastectomy. The same is, of course, for the axillary surgery, which has had a great development during the last decades. In the first times and more or less up to the 50s, it was always a complete axillary resection, and then even less up to the 1994 when the sentinel lymph node was for the first time performed. So an evolution, this is a sentinel image for a sentinel lymph node research. An evolution over the clinic, but no evolutions over the protocols. That's because there are many possible diagnostic and therapeutic options, and there are many possible breast cancer managements. There is no agreement nowadays about a best diagnostic and therapeutic pathway, and normally, generally, the clinical activity is organized according to the necessities, the needs, the structure, and the requirements of any single hospital. So I would like to take a look at 3 possible pathways. The first one is the one we have in our structure, in Italy. We offer to any patient mammography, a breast ultrasound to assess the diagnosis of disease. And when we have a diagnosis of breast cancer, we offer to any patient a breast MRI. And this is because we know, and previous colleagues who have spoken have said as well, that there are many possible satellite foci surrounding the main lesion which could not be seen through mammography or breast ultrasound. The possibility to misfind these little satellite nodules might lead to an earlier cancer relapse than finding, of course, these satellite nodules. So breast MRI is offered to all the patients, and during the surgical operation, the sentinel lymph node analysis is done immediately, during the operation, so that we have its frozen sections, so that we had the possibility to know during the operation whether the sentinel lymph node is healthy, and then we don't need to go further with the axillary resection, or in the other case, if the sentinel lymph node is ill, contains disease, we had to go on with the axillary dissection. There are other structures which are well renowned, for instance, the ones in Milan, in Italy, which offer just mammography and breast ultrasound, but not to any patient an MRI, because MRI is offered just in selected cases, but they do, as we do, a sentinel lymph node surgery with an immediate pathologist analysis. Normally, many other hospitals, I come from Italy, I had to say 80% of hospitals in Italy follow a standard pathway, which means they offer a mammography and a breast ultrasound to all the patients, a breast MRI just in selected cases, which are the cases which are supposed to be not clear, but as I told you, mammography and breast ultrasound may not see the little satellite foci which are surrounding the main lesion, and they offer a sentinel lymph node surgery with a delayed pathological analysis, and then, should the sentinel lymph node containing metastasis, this would require a second operation. Then, which are the pros and cons of these 2 possible differences in breast cancer protocols. The pros of a breast MRI are, of course, that it's a functional exam more than an anatomical one. It needs a medium of contrast, which is more or less analergic, has a high sensibility, has a low number of false negatives, and finds, of course, the pathologic microspots. This is the reason why we do this exam. Of course, there are some cons. There is a low specificity. MRI sees many spots which could not be a breast cancer and has a high false positive rate. On the other side, an immediate analysis of the sentinel lymph node has as pros, of course, the possibility to have an immediate result and to reach a clear surgical strategy, and as a constant time for analysis. This is a contra which has been overcome from a new way to examine the sentinel lymph node, which is called OSNA, which uses the nucleic acids and a PCR to see whether there is the DNA of a breast cancer or not, and this is much faster than a traditional analysis. This is an image, of course, of a breast MRI. Our study then, we have made a study based on costs. Something I would like to tell you before analyzing the studies is that, of course, these are costs which are fit for my country, for Italy. I mean, these are the costs of any of the paths of the three pathways. This is not the cost we offer to people. This is the cost we have as a national sanitary system. Then, the aim of the study is to assess whether doing an MRI and a sentinel lymph node analysis in immediate sentinel lymph node analysis to any patient, which is of course a cost because there are many patients who receive a breast MRI and don't need it because they have no changing in the diagnosis of dimension and position of cancer. This is, as I told, to assess whether this cost is higher than reoperating a patient because we have made a mistake, because we have misfounded some satellite foci which have led to cancer relapse, which is of course requires a second operation, and which is of course not just unethical but is a cost as well. The same is the study for the sentinel lymph node. Of course, it has a cost. I mean, freezing a sentinel lymph node and requiring the time for a pathologist during the operation and a longer operating time needs a higher expense, but we had to assess whether this is higher or not than operating a patient for a second time to perform a delayed axillary resection. Then, this is exactly what I told you. MRI could lead before the operation to a change of the operating program from an eventual conservative breast surgery to a mastectomy. I mean, should we find some satellite foci, should we find a multifocal or multicentric disease which was misunderstood during breast mammography or breast ultrasound, the MRI could lead us to change our surgical program, and this is the same for the immediate sentinel lymph node analysis. The question then is whether is it expensive or not. We have studied more 750 patients, 767 patients, and our study has lasted for 5 years. These three structures, I mean Ascot, G2 Clinico, and Nysen, are the three systems we use in our hospital to collect any information about the patients. I mean, this G2 Clinico is the Italian system, clinical system to collect information from patients. Nysen is the Italian network which studies which are the cost effectiveness of the exams Italian doctors do, and Ascot is our computer provider from our hospital. Then we have analyzed Whether the MRI was done or not done, there are, of course, cases in which also we haven't performed the MRI. For instance, very fatty breasts don't need an MRI, and we haven't done it. We have done a comparison with the basic diagnostic exams, so we have compared the two diagnoses, and we have seen whether MRI has been effective in modifying the therapeutic pathway. We have then studied the kind of operation, the fact whether we have done the sentinel lymph node biopsy or not. There are, of course, many patients who have an extensive disease in axilla. They don't require, of course, a sentinel lymph node biopsy. We haven't done it, but we have considered this number in the number of the patients. We have seen whether after a sentinel lymph node biopsy there was a dissemination of disease or not, and then what was to be done afterwards. Then the surgical duration in hours, which is a cone of our pathway, and the hospital stay in days. We have analyzed then the operatory cost for each minute. Of course, this is based over the Italian costs, and it is different between the two possible operations, I mean between the radical breast surgery and the conservative breast surgery, because the two operations last for a different time. We have analyzed the hospital costs in days. I can tell you that in Italy, a surgical hospital bed costs more or less 570 euros each day. This means more or less $700 and 400 pounds, more or less. And the cost of a delayed axillary dissection operation and of its hospital stay. We have applied all the cost parameters to the three pathways considering our group of patients. This means we have seen how big was our expense, and then taking our patients, we have put our patients in the other two pathways, and we have seen how would have it cost should we have followed one of the two other pathways. We have had 489 breast conservative surgery and 278 mastectomies. We had done the sentinel lymph node biopsy in 559 cases, and it was positive in 90 cases. This is more or less 16% of cases, and this is on the same line with the literature. The MRI has changed our therapeutic plan in 63 cases over the 619 cases in which we have performed these exams. This means that 10% of people would have a wrong diagnosis shouldn't we have done this exam. These are our examinations. This is the duration of the operations in hours, and this is the duration of the hospital stay divided into the 4 possible operations. This means breast conservative surgery with or without sentinel lymph node biopsy, and mastectomy with or without sentinel lymph node biopsy. Our results then. One MRI in Italy costs to the National Health System 323 euros. This means the cost of the machine, the cost of the time we use it, the cost of the personnel who works there, and so on. 1 day of a hospital stay, as I told you, 570 euros. An immediate sentinel lymph node evaluation, and this contains the time we need the pathologist, this contains the specimens, this contains the machines, and so on, costs 112 euros, but the cost is quite the same for a delayed sentinel lymph node evaluation, which is 107 euros. The operatory room cost per minute is the one you can see. The cost of a single delayed axillary dissection, which means what we can avoid during a sentinel lymph node biopsy during the main operation, is more or less 4,081 euros, and the cost of a surgical radicalization, I mean a second breast operation, is 5,717 euros. If we exclude the cost of the MRI, which is a cost we have already paid to avoid the second operation, the number we have to consider is 5,394. Summarized, our structure has paid for the 767 persons 3,825,000 and so on euros. The other structures would have paid more than us. This means that we have saved more or less 150,000 euros in comparison with the most renowned center in our country, and more or less €500,000 in comparison with the standard pathways the normal, so to say, normal hospitals follow. This is, of course, coming from our numbers. There is, of course, a break-even point. I mean, if we do an MRI to any patient, as I told you, we have to assess whether it's more cost-effective and cheaper than not doing it. There is, of course, a moment in which it becomes cheaper. In our group of patients, the break-even point after which we may say an MRI is cheaper doing it than not doing it is 37 patients. We have found 63. As I told you, 10% of people reach a wrong diagnosis using mammography and breast ultrasound. This means that if you operate more than 300 patients, you will be cheaper if you do MRI. And for the sentinel lymph biopsy, that's for less than 1 patient. MRI is a tolerable exam, and using it, in my opinion, is fair, conscious, and useful. The last slide, just the last slide, is just to show you, and I leave it here, what could somebody do using the money has saved using a good breast cancer pathway. I mean, these are the numbers of things one may do using this money. I mean, how many MRI, how many hospital stays, and in the end, how many doctors could one hire reusing this money, how many nurses, how many auxiliary people, and so on. And thank you very much.